this week on the BackTable podcast.
The fact that we even have this discussion with patients with HCC is tremendous. Again, we've discussed about the impact that immunotherapy has had, where all of a sudden this was considered a very difficult patient population to study. And now we're considering some of these novel therapies in them. And so that's a tremendous progress right there. There are, some proteins, GPC3 being the one that I can think of off the top of my head, that there are bispecific or T-cell engagers that are being developed for that. And HCC is one of the tumor types that they're considering using those in. Similar with CARs, that again, GPC3, developing CARs to GPC3 where you can give, cellular therapies, again, targeted towards that. I think those will be very attractive when you're trying to sell it to patients, right? GPC, and you're now pulling their T cells into contact with the tumors. That sounds pretty cool.
Welcome, guys, to our next episode on our HCC weekend here for BackTable. We are going to be discussing a little bit of a different topic with HCC, and really that's where we go from here. What does the future hold? What are the novel strategies that we're utilizing or we're seeing clinical trials being run or different institutions are doing that are trying to move the field? So we've talked about first line, we've talked about second, third line, and this is really kind of what's next, what's on the horizon. The first thing I want to start with is, there have been some recent studies looking at expanding beyond PD-1, CTLA-4 in terms of immune checkpoint blockade. So, Lingling, why don't you walk me through at least one example of one of those studies?
I think about 2 years ago, when the anti-TIGIT data was presented at ASCO annual meeting, that was almost like the most exciting moment. And then we all felt that was going to be like maybe the next approved one, right, for HCC. And then that was phase 2 data that they combined anti-TIGIT antibody with Atezolizumab and really showed that anti-TIGIT plus Atezolizumab, the median progression-free survival was great. So all looked great. And then we actually also had the phase 3 trial at Ochsner at that time that most recently they did publish their data, and then they did not. They missed their primary endpoint. So that will be a negative. So anti-TIGIT probably will be off right now.
Yeah, TIGIT, so it's another immune checkpoint, and it was kind of got a lot of hype for a while, and
right.
It was actually studied in gastroesophageal cancer, right?
We had a lung cancer as well, right?
Lung cancer. We had a first-line gastroesophageal cancer study that turned out to be a negative study. Mm-hmm. The question is just adding more, immune checkpoint blockade going to really be the next answer? I think the jury's still out, but so far it's been a little bit disappointing in that world that we're going to be able to just throw another immunotherapy in the frontline setting.
Yeah, they're still out there. I mean, there's TIM-3 is another one that people talk about a lot, that the studies are still going to happen at some point, do we say that two is enough, and then
there's also like immunomodulator trying to enhance the anti-tumor response as well.
So they'll still happen. We're just still waiting on another one to hit.
Still waiting for the next one.
So one important strategy that we adopt a lot at our institution, but I think the prospective data is probably lagging a little bit behind, is combination. Mm-hmm. So combination, we discussed briefly in our first episode about which immune checkpoint combination regimen we would use when we're using it combined with local regional therapy. But just speaking about that data, just more generally, there have been several prospective trials that have been run in this space and that are ongoing as well. Emerald, Leap kind of are the big ones that are looking at combining local regional therapies with immune checkpoint blockade. Most of them historically have been with TACE. I think a lot of the field in interventional radiology, though that's not our area of expertise, is moving towards radioembolization with Y90. So that's something we're doing a lot of. So what's been, I know Lingling's experience because it's very similar to mine, but Craig, is that something that you guys are doing a lot in Charleston? Or
we are. As you said, there's a space here where liver-directed therapy plus, where do we put the systemic therapy in that scenario? As I said, it has been mentioned, neoadjuvantly before resection. After resection, should we consider it there? Around TACE and TARE, at some time point before, after, what all those, different scenarios have to be worked out. But it's definitely an area of active research as far as there are clinical trials out there. There are some institutions like ours that are doing it with, there's data there, but there are prospective studies that are going to try to address this this particular question in a scientific manner. But I would say that there are many institutions that are already sort of combining liver-directed therapy and systemic immunotherapy.
Right. To me, I do feel that exciting. We actually have been combining immunotherapy with radioembolization at Arsenal. We do more Y90 for many, many years. Even before we started using Atezolizumab in the frontline setting, we were combining nivolumab with Y90 at that time. And we do have patients with great response. I even have like stage 4 patient, oligometastatic disease, had a complete response a lot for years. So I think there are patients who really benefit from this. When it comes to the LEAP trial and the EMERALD-1 trial, first of all, these are global trial, large phase 3 international trials. So Y90 in a lot of countries, Y90 is not approved yet. So they have to use TACE instead of Y90. And then the patient population is completely different from the patient population that we typically see, like advanced stage, either BCLC stage B or stage C. For those trials, the majority, it's really intermediate stage, right? The majority of patients had BCLC stage B disease, and some of them had stage A disease. Very, very few patients had stage C disease. I think only 9%, like single digit in the LIP trial. And then, true, both trials show that the combination systemic immunotherapy versus plus TACE versus TACE alone improve progression-free survival. The overall survival for both are not mature, so we don't know, but it may or may not be positive. We just have to see. But when you think about these patients, these are not curable patients still. And from my personal experience, we had actually some people with great response, right? It's after many years, it's still complete response, no evidence of disease on the scan. At least in my mind, for these patients, it is important. Like after years and years of treatment, then when you do a scan, it's still complete response. For them, they feel very secure or reassured.
Well, we published our own institutional data recently, and those patients who did have a complete response at the site that was treated, the Y90, really did have excellent
like
survival.
Superior, progression-free and over survival.
So the way I kind of frame this question of the combination is I think they're very heterogeneous patients, right?
Right.
There's the group of patients who are BCLC-B intermediate stage and are using systemic therapy earlier than you otherwise would have, right? Someone who's not curable, that either they have multifocal disease or they're too big to get to transplant. And you're saying, hey, can we improve your survival by intervening earlier? Maybe can we downstage you? I mean, I think those are kind of what you're trying to do in that population. And then there's a bucket of patients who have metastatic disease. And even within that, I think there are two different different populations. There's the population
widely metastatic versus oligometastatic.
Right. And if you have your widely metastatic, the rationale might be that like maybe this radioembolization's stimulating
immunogenic
an immune response and neoantigen expression in the tumor microenvironment, and the immune checkpoint blockade is then coming and going to enhance the effect and the abscopal effect and all that. But there's also what I think is a little bit more common is someone who has high volume liver mets, or maybe a single dominant liver met with oligometastatic disease. And those patients, they're probably going to die from their liver disease, or the cancer in their liver, I should say, maybe their cirrhosis as well, but not their oligometastatic disease to their lung or their adrenal gland. So I think that is, to me, is like the optimal candidate for a combinational approach in the BCLC-C setting. And I think potentially both of those in the BCLC-B that we talked about. But that's kind of how I frame those two different populations. And since it's so heterogeneous, I think it's going to be hard to show that in a trial.
Right,
so
right.
I'll be interested just to see how all this data plays out over time.
Right. I do feel that I know from my practice that there are people who benefit from it, and there are people who don't benefit from it, just keep progressing. We just cannot tell ahead of time, like who are those people who will benefit from it.
You guys doing any SBRT at all with any of these? I know that the dose of radiation is higher with TARE versus SBRT, but any thoughts around that? We do have a few cases that have done SBRT, well, again, with single lesion, those kinds of things, or multiple smaller lesions, that kind of thing.
Liver-directed SBRT, we're not doing a lot of. So I think, again, this is going to be very institution dependent, right. I think. And I think our IR group is much more involved in our liver population than our radiation oncology group. And you mentioned the higher doses. So, obviously if a patient has a lung met and we're trying to treat their oligometastatic disease, that might be an SBRT candidate. But for the liver, we're predominantly not quite exclusively, but predominantly using Y90.
Yeah, I think in the liver definitely, but also a patient HCC like oligoprogression is only in, say, periaortic lymph node, then we use SBRT.
Yeah. So you mentioned, Craig, earlier the perioperative setting, and I think that's something we haven't really discussed, is that, there's a group of patients who, leaving transplant aside, but who may otherwise have a healthy enough liver to get to a resection. And there's a lot of interest in looking at, I know we're, talking with MD Anderson about maybe going on a neoadjuvant protocol for resectable HCC, utilizing immune checkpoint inhibitor. So I agree that that's probably going to be an area of, active development. I think the question is, how many patients do we see that are actually good resection candidates? And could it be helpful for those patients? Sure. We already know that adjuvant therapy,
doesn't work.
At least at present, what's been studied does not seem to have been terribly beneficial.
Right.
So I don't know. Let me ask you, do you have a lot of hope for neoadjuvant?
So again, as a GI oncologist, we see a lot of different kinds of GI cancers, right? When you think about, if we take a step back and think about colorectal, right? Neoadjuvant seems to be a heck of a lot better than adjuvant. Now, we don't have that. That's not been proven yet, right? We have clinical trials where you give neoadjuvant therapy to patients that are, mismatch repair deficient, and there's a complete response rate that's tremendous, and the partial response rates are tremendous. And then, so you could actually spare them probably adjuvant therapy. But, the adjuvant therapy clinical trial, you have to get 6 months of chemotherapy and a total of 12 months of immunotherapy, thereafter.
Right.
Could we expect something like that in HCC? I don't know. But it does give me a sense of optimism that doing immunotherapy upfront, again, to the correctly selected patients, could that be something that's actually really beneficial for those patients? But again, I'm extrapolating from a different disease type. We all know that, gosh, not even two patients are the same, much less, different diseases. But it does give me optimism that that might be a worthwhile clinical scenario to explore.
So another area of interest in terms of looking ahead is, some targeted therapies. We talked in our last episode that we don't know a lot of the targets in HCC, and the ones that we do don't seem to be driving the HCC. A lot of that comes from us not doing a lot of biopsies, using some ctDNA, but there may be some room for targeted therapy in the sense of cellular therapy, which is not in the same bucket as targeted therapy, but we're identifying a overexpression of a protein and maybe trying to engineer a CAR construct or perhaps a bispecific agent that could target that. So I think these are very early phase, right? These are in the phase 1 setting, but I remember being at ASCO this last year, and there have been some data that are coming out about both CARs and bispecifics that show some promise.
The fact that we even have this discussion with patients with HCC is tremendous. Again, we've discussed about the impact that immunotherapy has had, where all of a sudden this was considered a very difficult patient population to study. And now we're considering some of these novel therapies in them. And so that's a tremendous progress right there. There are, some proteins, GPC3 being the one that I can think of off the top of my head, that there are bispecific or T-cell engagers that are being developed for that. And HCC is one of the tumor types that they're considering using those in. Similar with CARs, that again, GPC3, developing CARs to GPC3 where you can give cellular therapies, again, targeted towards that. I think those will be very attractive, less so the bispecific, but more, both of them attractive in that, you're trying to sell it to patients, right? GPC, and you're now pulling their T cells into contact with the tumors. That sounds pretty cool. And then with something like the CARs, that you're expanding them outside, so you're giving the patient their own cells back, but they're again turbocharged and now coming back into the patient. So I think those could be really attractive things. Now, which line of therapy? And again, it's you don't have a ton of patients with HCC that are third line and beyond that are going to be able to tolerate the kind of preparative regimens that are associated with CARs. I think the bispecifics might be a little bit easier to tolerate for those patients. You don't have the same chemotherapy preparation that's required. And so I have some optimism about those things, but I don't know about the utilization long term until we get better at first and second line treatment, so that we are seeing patients in the third line setting, or those are going to have to be moved up relatively early in the treatment course to give patients the best access to them if they're working.
It's a great point. I hadn't really thought about, how patients would tolerate the, ablative chemotherapy that would have to be given before you would give them a CAR, whereas you don't have that problem with the bites, right? So, you think about your small cell population, and now they have their DLL3, bites that are approved, tarlatamab, and that's a population that you don't think of as being the healthiest either, but they can seem to tolerate that as well as could be expected. Maybe you could think that a similar, if you found the right target in HCC, could also be well tolerated. So that's actually a great point.
But again, I think in the reality, the biggest challenge for us in HCC population is their liver is not healthy, right? And over time, the longer they live, the more likely their liver function can deteriorate over time. Like if you think about it, it's interesting, right? HCC patient, the lenvatinib dose and cabozantinib dose the lenvatinib dose is way much lower compared to the dose we treat with RCC and
thyroid.
I think thyroid cancer, right?
Yeah.
And then apparently I think the RCC and thyroid cancer patient can tolerate a much higher dose, but our HCC patient are not able to. So I definitely feel that the liver function plays a role there.
Well, Craig, have you ever had an experience with downstaging one with ICI and getting them to a liver transplant?
I've not had that particular experience. I've had the experience of taking care of a patient who had a liver transplant, then came back with HCC later.
Yeah,
that I've had experience.
How do you manage that? Because that's not a terribly uncommon situation. We see it from time to time.
The presentation of those patients, I've had 3 now. I've had 3 in the last 6 months referred to me for, 2 of them have HCC that recurred. One of them in the lungs, one of them actually in the liver, and another one who has a different kind of cancer altogether but would require immunotherapy for that. And so it has caused me to do a lot of digging into the medical literature about what do you do with these cases, right? The dogma that's out there is somebody who's had a transplanted organ, you do not do immunotherapy. That's a dogma. They're going to reject their organ. You're a crazy person if you're
50% chance that they're going to reject.
If you're going to do that, it's so not a lot of good data out there. A lot of case reports, a lot of sort of multiple cases. Some institutions have 3 or 4 cases they could talk about. There was one published last year that was a systematic review that I think looked at 52 cases. And so that's kind of been informing my decision about the management of these patients. They found the rejection rate to be right around 30%, liver rejection rate being right around 30%. Although that did decrease over time. Initially, it's sort of the Kaplan-Meier curve, started steep and then flattened out. And so that initially, a high number of patients were rejecting. It was 4 patients a month or something like that were rejecting. And then it went down to 2 patients a month. And then after that, it stabilized at a much lower level. So there is a tail. We've been talking about the tails on the curve. There's a tail on that curve as well, that the rejection, while 30% does tail off over time. There are the people who were able to get past the rejection part. I know that's easy to say, get past rejection, get along with it. People who were able to get past rejection, there were decent response rates in those patients. Now, the response rate had to do with how long, at least when there was some association between when was the liver transplant given as to where, when was the response. I would have thought that the rejection would have been more, the outcome associated with the proximity to the transplant, but that didn't seem to be the case, at least not in this study. Didn't seem to be the case. It was more the response. And they did a ROC curve analysis, and it was like 3 years and 10 months. If your liver was 3 years and 10 months, you had a better chance of responding. They did not see an association with rejection with timing, which I found surprising. Another thing they saw that needed exploration was that some of the transplanted livers express PD-L1. And if the PD-L1 expression was high, you're more likely to reject the liver. And so there are more and more of these patients that may show up. As I said, right now I have 3, and it makes you question, what are you willing to tolerate? In that same systematic review, I think 7 patients died. 7 out of 52 patients died from their rejection, 13%.
Right. Yeah.
And so, are you willing to hold hands and go down the road with a patient like that, where their risk of actually dying from what you're giving them is that high?
It's a real risk.
And that has been interesting to me. And then the other part is that we haven't talked about a little bit is the difference in HCC in the United States versus other countries. In other countries, a lot of, hepatitis, viral-related HCC. And here we're seeing much more of the metabolic, NASH, that kind of thing. And does that change the way we treat these patients? And I think those are things that are going to be elucidated probably in the next few years.
Right.
Yeah, no, that's great overview. I mean, I've had a handful of post-transplant recurrences. I have not pulled the trigger on a immune checkpoint inhibitor yet.
Right.
All of them I've used TKIs and kind of cycled through the TKIs. I will be honest, I don't tend to see a lot of responses. I think if I get some stable disease, I'm pretty happy, but I feel like that post-transplant recurrence tends to be relatively aggressive
Right.
and non-responsive. There's also been talk about affecting modulating the immunosuppressive medications, right? So switching their immunosuppression, maybe backing off their immunosuppression a little bit. That really has to be done in tandem with the transplant team. Obviously, I'm not going to touch their Tacro and
I
mess
just
with
feel that, like for me, I also have quite a few patients who develop our HCC recurrence after transplant. And of course, I personally have never used immunotherapy in this setting and always just sequenced through TKI. I would say the prognosis pretty grim. Like HCC, whatever cancer malignancy they develop after transplant, I do feel that because their immune system is suppressed, the cancer tend to be more aggressive, and the majority of patients actually blow through all the TKI, and then so we're talking about a very bad prognosis. I only had one patient with lung mets after transplant that was on one TKI for 3 years and the other TKI for 2 years. But I don't think it's actually, I feel that it's the biology of the cancer. He had well-differentiated HCC. So his cancer probably like very, very slow growing to begin with. But all my other experience is pretty poor. And speaking of that, we're talking about the adjuvant setting. In the neoadjuvant setting, I don't think, at least in our institution, we don't intentionally do that, right? It's not that, hey, I know that your goal is transplant. By the way, let me just give some immunotherapy to treat it. That's not our protocol, but we did have patients who just initially came in with like not transplantable disease, but just respond to immunotherapy so well that eventually they become a candidate for transplant and they receive a liver transplant. I know that with our experience, from what I heard at Tumor Board, like our experience has been like okay, like safe, they did well after transplant. But I also had that at other institutions, sometimes that I do heard that they had bad experience that after they stopped the immunotherapy and gave people a transplant, and still people developed like very bad acute rejection that was like almost unable to control.
They mention, they've talked to us about 3 months.
Right.
Yeah. But they're, hepatologists, what they think of immunotherapy, we don't necessarily think of immunotherapy. They were talking about panitumumab and all these other things like that's not, that is not what we consider, immunotherapy. But the recommendation currently, I think, at least from our transplanters, is about 3 months before.
Right. I think 3 months is probably because of the half-life. We just count the half-life of these antibodies.
But there are increasing data that are coming out that are trying to provide a little bit more guidance there.
Yeah.
Mostly out of Europe is what I've seen.
But I also do feel that, think about it, what we learned from immunotherapy, what we were taught was like, say you're on immunotherapy for years, there's no specific timing that you will develop immune-related severe adverse reactions, right? You can develop within 3 months, you can develop like after being on it for 3 years, right? We just cannot predict when you're going to have that. So that's actually my question is like, how can we know?
How can you know?
Right.
You could reject it over 2 years later.
Right.
Any other kind of thoughts you guys have about the future? I know HCC, we kind of feel like we've hit a little bit of a limit in terms of first-line therapies, and we're trying to think what we can do. We can broaden the categories where we're treating, in terms of earlier stages and, the neoadjuvant setting or the combination setting. And then really, I think if we can tap into cellular therapy, I think that's going to be a huge plus for our patients.
I actually feel that one of the future for us as medical oncologists is we'll start playing a more and more important role in even earlier stage HCC that we typically, like in the past, say 5 years, 10 years ago, we only see the patients when they have no other taste options. They were sent to us and first to start sorafenib. But right now, I'm definitely treating a little bit earlier stage patients with HCC with immunotherapy for sure. And then sometimes I even think about like if patients have resectable HCC, but a big HCC, not a small one. Should we do resection? Should we do neoadjuvant systemic therapy, try to shrink and do resection? Or should we do Y90 combined with immunotherapy? It's just a hypothetical case that I was just thinking about. But I do feel that we are trying to, and we are stepping in and will more be in the world of earlier stage HCC.
Lots of interesting things to explore.
Right.
Great. Well, thank you both for this great discussion, all 3 of these episodes, and I certainly learned a lot. And Dr. Lockhart, Dr. Du, enjoyed speaking with you, and I appreciate you sharing your experiences, and hope we get a chance to do this again.
Absolutely.
Thank you.
Thank you for having us.
Thank you for having us.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.